fibrosis of the transverse process to the sacroiliac. And sometimes they have the pain on that side, or they can have it on the contralateral side that is swinging. So you want to make sure that you're not just assuming that the pseudo side is the painful side. Once you do the exam, you send them for the injection. And when you do the injection, if they get relief, they're so happy that you found their diagnosis. And then you do the injection, and then you put the screws across. Now, some studies say you can cut out the transverse process and resect it, but you're not addressing the SI pain. You're just resecting the butterfly fragment. So my suggestion is don't make the surgery any bigger. You just, once you localize the pain from the butterfly fragment or the contralateral side, or both sides, you fix it. But so I fixed 20-year-old, one of my office staff was 20, and she had butterfly fragment, and her mom is my patient that had cervical surgery, and I said, she needs to have an SI. And she couldn't sit for a while. And the other classic symptom here is if you sit for a long time and it's hard for you to get up, that's SI, until proven otherwise, because you're putting that stress on the SI joint from sitting to standing. If you drive and you drive after 2 hours and you have to get out of the car and you dread coming out of the car, that's SI. If you have groin pain that is not related to your hip arthritis or FAI syndrome or labral tear, it's SI. If you have pain that is not in the midline, so a midline pain is not SI pain, that's back. Off midline pain is SI until proven otherwise because it's in the dimples. So that's what we call it the Fortin's finger test. So if you do a Fortin's finger test and they jump off the bed, they have SI until proven otherwise. If you do a straight leg raise and they jump off the bed, they don't have SI. That's disc. So you just have to kind of do your exam, but I've done this in 20 years and it doesn't affect sexual life, pregnancy, anything. Because remember, the SI joint does not move. It only moves about 2 to 4 millimeters front to back. So when you have hypermobile and you go from 2 to 4 to 7 to 10, that's too much movement of the SI joint. So all you're doing is you're just restoring the SI joint to where it's supposed to be. It's the opposite of lumbar fusion where you're taking a mobile segment and you're fusing it. This one, you're fusing something that shouldn't move. So it's like, I always tell the patient, it's a win-win for you. I'm not taking anything away. I'm restoring the integrity of the SI joint. And you can always take the screws out. If the patient wants it out, after a year, you take it out. All right, on Saturday we have another talk on the case series of the same technique, so hopefully you guys show up. I just need a confirmation of the time.